Ladies and gentlemen, our next guest speaker is Dr. Andrew Chanen, and I'm suggesting perhaps some of you may have seen him speak before. So Andrew is a consultant psychiatrist, associate medical director and an associate professor at Orygen Youth Health Research Centre. He is also the president of the International Society for the Study of Personality Disorders. He's a member of ICD-11 reference group for classification of personality disorders and a member of the federal government reference group and BPD guideline group. The guy knows what he's talking about. Ladies and gentlemen, can you help me welcome Dr. Andrew Chanen to the stage, please?
Well, thank you very much, and thank you very much to the organisers for inviting me today. And it really is wonderful to see so many people here and to have such an incredible turnout to this conference. Lest this sound like mutual admiration, I actually wanted to pay tribute to Jan. I was planning on doing it beforehand, I think. And I really want to say that a lot of the effort that I think some of us probably take for granted in the development of advocacy for borderline personality disorder is actually due to Jan's efforts, particularly the establishment of the expert reference group, the guideline development group, and if you've ever seen her in action, she's a force to be reckoned with, and I think we all owe her a great debt of gratitude. So I'd like you to join me in thanking her. So what I want to talk to you about is about rethinking how we approach borderline personality disorder. Too often our approach has been from the wrong end of the problem. I'm just going to tell you a little bit about where I come from, for those of you who don't know, that we're a youth mental health service and we have a clinical program, research program, and a training and communications program. And the program I'm going to tell you about spans all three arms of those aspects of Orygen. The clinical program itself covers the west of Melbourne, and we offer a broad, comprehensive clinical program. And within that, we've developed a program for prevention and early intervention of borderline personality disorder, which we call HYPE. And this is my summary of how we approach the problem of borderline personality disorder. We try to unscramble eggs. And we wait for too long until the problems become intractable. And I fully accept that clinicians are master chefs in this aspect as well, that we wait until problems are established and entrenched, and then we try to unpick them. We try to separate out the yolk and the white, and we feel, very proud and satisfied if we do see a bit of yolk and white. And I think that most of the approaches to the treatment of borderline personality disorder have been successful to that extent. And everybody who has developed one of these treatment approaches would fully acknowledge that they're not good enough, that we don't achieve enough and work with people with borderline personality disorder enough to be able to, be satisfied with the outcomes of treatments. We need to do more. And I think Flick said it this morning, that she's tired of people saying we just need more money. We don't just need more money. We need more science. We need more input from people with BPD, from families, and we need the buy-in of government, obviously. And I'm pleased that we do have the interest that we do from government in this problem. So we all know this is a severe problem, and so prevention and early intervention have face validity. It makes sense that you would want to act before problems become entrenched rather than wait until the horse is bolted. This is one approach to prevention and early intervention. Don't be afraid, we're grief counsellors from California. This is the equivalent of, I'm glad I got a laugh down there. Michael Lunig is a gift to presenters with interested in personality disorder or prevention. The idea of parachuting people in to a war zone and saying it's okay, we're grief counsellors, we're going to fix the problem, I think is a nice summary of some of the difficulties with prevention. These people are still going to be living in a war zone. They're still going to be experiencing difficulties, and there's not that much that grief counsellors taken well out of their context can do in this kind of setting. There are models for prevention of personality disorder. Antisocial personality disorder does provide us with some clues, although the fields are quite different and have developed quite separately. We do know that the pathways to developing antisocial personality disorder are actually very well described, and there are natural interventions that follow from every step of that pathway. And I've argued now for over a decade that the strongest case is for moving that effort onto borderline personality disorder. It might be that schizotypal personality disorder is another candidate as well, requires quite a different approach. But the main reasons for choosing borderline personality disorder are that it is, from a clinical standpoint, i.e. from a functional and interpersonal standpoint, the most severe of the personality disorders. And there are effective interventions that give us hope that we can actually help people to change and that we can change in response to them as well. But this was one of the principal problems that we started with, that personality disorder in young people is actually the diagnosis that dare not speak its name, that people are reluctant to make the diagnosis, to use the label, and sometimes for very good reason, which I'll get onto. But it has been a tremendous barrier, the reluctance to see that this problem, although everybody acknowledges that it has its roots in childhood and adolescence, people will wait until it's absolutely not just bleeding obvious, but until the damage is done before they actually decide to make the diagnosis and offer intervention, if they do at all. So what we're talking about with early intervention and prevention is not just about the diagnosis or the diagnostic features of the disorder, but preventing the kinds of tragic outcomes that we all know are associated with the disorder, and helping people to have a life course trajectory that is much more of their choosing and their desire, to help them to have a more adaptive developmental pathway, whatever it is that they choose. So what's realistic now? What can we actually do in terms of prevention and early intervention? Linig's helped me out again. Son, I'm worried about your mental health. Sitting in your bedroom doing this self-harm nonsense, get out and do some harm in the world like normal, successful people do. And I think the problem is that that either, we think tough love might do it, which clearly it won't, but also we think, well, people with BPD have had difficult lives associated with a great degree of trauma. If only we could stop the trauma, well then that would fix things. I think there's been there's a great difficulty in thinking about prevention from that perspective. And the problem is that when we talk about prevention, we don't mean one thing. Some of you might be familiar with this schema, which describes the different approaches to prevention, from whole population approaches, universal approaches like vaccination or school-based mental health type programs, through to selective programs, people exposed to risk factors for mental disorders, and then indicated prevention, which is targeting people who are starting to develop disorder but don't necessarily have the full disorder, and then on to early detection and treatment, which is what I mean by early intervention. And if we think of selective intervention or even universal intervention, if we think about reducing abuse, neglect, those kinds of problems, they are tasks that government and social agencies have tried to do for decades and are noble and worthwhile aims in themselves, because these are immoral, harmful and wrong things with our society. But the idea that they will prevent borderline personality disorder is not supported by any evidence at this stage. We need evidence, but the data don't actually help us to design such programs, and in fact the science of proving these programs is actually, at the moment, beyond our capabilities. So we've argued that the best bet at the moment is not to abandon those programs of trying to reduce rates of harm in society, but if we want to prevent borderline personality disorder, we need to hone in on the features of the disorder and start picking people up early and intervening and helping to avert some of the consequences that we all know about the disorder. And this is just a kind of schematic representation of how we might think about prevention. At the top end there, the kind of high prevalence common things that we think about, people who have a vulnerable temperament, people who are exposed to abuse or neglect, those kinds of things, we can't do this alone. We need to join with other groups, with other fields who are trying to prevent poor outcomes from these kinds of general harms in society. And we need to measure those harms as outcomes. Borderline personality disorder is never measured as an outcome from studies of universal or selective prevention. People might measure depression, anxiety, physical health problems, but no one ever measures borderline personality disorder, and we don't know whether parenting programs, school support programs are enough to prevent the disorder. And in fact, BPD is a fairly rare outcome from these kinds of risks. It's much more likely that if you're exposed to those risks, you'll develop anything other than borderline personality disorder. So there's something special about the interaction between those risks and the individual who is exposed to those risks. That means that we might need to provide more for those people than just general preventive programs, but we don't know. We need science to underpin that. What I do think we can do now with our present knowledge is to begin to pick people up early and, of course, to offer intervention to those people who have established borderline personality disorder and especially, of course, to those people with long-standing disorder. And after all, who's going to argue for late intervention? Who's going to say, let's just wait until the problem gets worse and then we'll intervene? Well, most of the mental health profession have said that up until recently. Nobody goes to emergency with chest pain and gets told, look, could you come back and if the chest pain goes on for another hour or two, maybe if it goes on for a day, come back and we'll see if you've had a heart attack. Nobody goes in with a breast lump and they say, look, let's wait and see if it gets bigger, see if it spreads, and then we'll offer you some treatment. But why do people do this? For a range of mental health problems, but particularly for borderline personality disorder, when actually we have enough knowledge now to know that the signs are there, that people who display these features in adolescence or young adulthood are at risk of going down a pathway of long-standing difficulties. And there are some differences in BPD when it presents early compared to when it presents late, but they're pretty minor. But most of the differences are actually that the mental health system itself hasn't had its impact on individuals with BPD and hasn't caused some of the harms and difficulties that we actually teach individuals or shape individuals with BPD into engaging in, which people think are defining features of the disorder, but actually they're responses to a system that is overwhelmed and unable to cope. What we know is that when you apply the same diagnostic criteria to young people, they're no less reliable or valid in young people than they are in adults, which is to say the cup is half full. They're also not that reliable and valid in adulthood either. But importantly, there's nothing special about turning 18. You know, you don't get the right to drive, drink, smoke, vote, and have a personality disorder when you turn 18. That these features have roots going back, and we need to find those roots and help to pick these problems up and to help people to make changes to their lives. And in fact, I would argue that BPD is a disorder of young people. If you look at the prevalence of the disorder, it picks up after puberty, peaks in the teens and 20s, and then drops off with every decade thereafter. So this is a problem that affects young people, and this is the time at which we need to be approaching the problem in a helpful way. If you ask adults with BPD, and there are many people in the audience with BPD, and I'd be interested to know if this is the Australian experience, Internationally, the studies that have done so, if you say, when did you first come in contact with psychiatric services? It's in their teens and 20s. The diagnosis might not have been made, they might not have been offered treatment, but they were in contact with mental health services, and the opportunity for early intervention was missed at that point. If you use conventional diagnostic criteria, these problems are already common in young people presenting to child and adolescent and adult mental health services. So that people are there. We're not inviting new people into the system. We're actually changing the way, putting on a new pair of glasses so that we can actually see the problem when it's there in the first place. And we know from a whole raft of studies, including our own ones, that if you apply the diagnostic criteria and you compare people who meet those diagnostic criteria, whether you approve of those diagnostic criteria or not, and you compare those to people with other personality disorders, or you compare them to people who have a mental health problem but no personality disorder, this is a group who are doing very badly right now. They're having great difficulties. So it's not like we're labelling people with something that isn't a problem or medicalising a problem. These are people with high rates of other mental health problems, high rates of substance dependence, high rates of physical health problems, sexually transmitted infections, a whole raft of problems that go along with this diagnosis that are all worthy of attention in and of themselves. But what's, I think, most concerning is that these problems aren't short-lived. That if you were ever diagnosed with borderline features or the disorder itself, then you're at increased risk for a range of problems down the track, such as particularly substance use and mood disorders, but interpersonal problems. We've heard about BPD as a relational disorder, and relational problems are at the core of BPD. But distress, reduced quality of life, a whole raft of problems that follow people. We know the data only go out to 2 decades. We don't know whether it goes on longer. And in fact, the study that is taken from is now collecting data of people who are now in their 3rd decade on. So what can we do? What does an early intervention program look like? And I'm not going to present data, I'm going to actually tell you what we do. And hopefully to give you the message, this is not rocket science. This doesn't require learning necessarily fancy new therapies. It doesn't require a great change in mental health services. It requires a change in thinking. But the basics of early intervention could actually be rapidly achieved pretty quickly if there was a will to change the way we approach this problem. So I'm going to tell you a bit about the HYPE program. The aim is to help people to function better in life, whatever that choice might be for them. And also, of course, to reduce psychopathology, depression, anxiety, and other problems that go along with it. But we also want to divert young people from unhelpful engagement with the mental health system, but not to say that, not to actually get them out of the system, to actually help to promote appropriate help seeking, to find ways that they can actually get their needs met down the track. Because actually, the paradox of BPD in young people is that this is a group that are going to have higher mental health needs in the future than their peers who don't have BPD. So they're going to need contact with the mental health system, but they have tremendous difficulty accessing either people who understand the disorder and are welcoming in the system, or finding a way to actually get help in a helpful way. And we've conducted a number of studies looking at the intervention in HYPE. I'm not going to go through the data for that. The papers are published. If you want them, you can email me for them or find them on the web. In fact, one of them, the main paper, is available free, the one in the British Journal of Psychiatry. What's important, I think, is that this is proof of concept, that you can do this. When we started doing this work, people said that we would make people worse, that it was unethical to diagnose the disorder in young people, and that this was likely to be a harmful practice. What's really important is that the people that we have, we see in our program and the people who've been in our studies are anything up to 15 years younger on average than the patients that you see in the treatment trials and the scientific literature. So we're accessing people much earlier in the course of the disorder. And as I've said, the main message we think from our work is that basic reforms to existing services are what are needed, and that learning brand name therapies are important, but they're a second stage of development of early intervention services for borderline personality disorder. There are risks though, of course. Lynig's helping me out again. Oh darling, what a pity. I think your interesting personality has just been classified as a personality disorder. There is a risk that we will medicalise a problem that isn't there. There's also a risk of stigmatising people by giving them a label that's just going to get them unhelpful engagement with the health system or rejected outright. So stigma is a real issue, and I actually don't accept that stigma is a big problem for the community. I think it's primarily a problem for the mental health profession. And I think ignorance is the bigger problem for the community, that actually there's just very little knowledge about the disorder in the community. But I think stigma is a huge problem, and iatrogenic harm, that is harm done by clinicians or the mental health system, not because people want to be harmful, but they don't know how to be helpful necessarily. We also might be instilling an unnecessary fear of illness. Given the data I just presented, you know, people might think they're ticking time bombs. But in fact, the outcome with treatment is good. And so we need to be optimistic that people can recover from BPD and can get on with their lives. We also need to be cautious because we're not just dealing with a local or a national scene, we're dealing internationally with mental health systems. And in some countries, overuse of medication, polypharmacy is a huge problem once diagnoses are made. So to get people into our program, we just use a simple screening measure, and it's actually a very efficient way of detecting people for further assessment. You can adjust the threshold according to the availability of your resources, setting it higher if you don't have many resources or lower if you've got plenty. We take people with 3 or more DSM borderline features. As many of you all know, you need 5 to actually make the diagnosis. But actually, BPD is a dimensional construct. It's not a categorical thing. It's not that you either have it or you don't. You can have some of it, you can have more of it, or you can have a lot of it. We set the bar at 3. The majority of people we see, though, do have the full syndrome. And we aim for people not just to give informed consent, but also informed refusal of the program. We don't accept people just simply not turning up as somehow saying that they know what they're knocking back, or that this is some informed decision about treatment. We actually make efforts, really strenuous efforts early on, to try and let people know what we have to offer and to help them to make an informed decision about whether they want or don't want intervention. We don't exclude people with co-occurring problems. One of the problems with some existing programs that are helpful is that they still have exclusions for people with other co-occurring problems. BPD comes with a whole raft of other difficulties, and cherry-picking people who don't have these problems really gives you a very atypical view of the world of BPD. You don't see the people with typical problems if you don't accept people with learning disability or substance use or problems with aggression and violence. You need to be able to find a way of accommodating those people into programs. And this is the norm. You can see there, I'm not going to go through all the details, but you can see there are a raft of problems that commonly co-occur with BPD. BPD is just your ticket into the program, but it comes with a whole lot of baggage. And that also includes things like learning difficulties, educational difficulties, vocational problems, problems with family conflict, which we've heard, family mental illness, and abuse and neglect and victimisation, sometimes which is still going on, which I think is one of the differences between early intervention and later intervention. But even in adults with BPD, we know that the traumatic experiences don't stop in early life, that in fact they continue into adulthood. And this is the model that we integrate individual psychotherapy with assertive case management. People get a thorough assessment, and we also have family involvement in the program. We have access to the common psychosocial recovery program at Orygen. And then we also, as I said, need to offer all the general psychiatric care that people with BPD will need. Treatment of depression, treatment of psychotic symptoms, treatment of anxiety problems, whatever it might be. It's primarily outpatient. We don't think that primarily inpatient-based programs are the way to go. We develop a shared understanding with the individual person and hopefully with their family of what is going on so that everybody is actually singing from the same song sheet. We've heard about BPD being a relational disorder. The idea being that actually we need to understand the problems from the individual's perspective, from the family's perspective, and for everybody to be on the same page in terms of their understanding of what is going on. And we integrate into the intervention other successful techniques from other interventions, whatever works. So there's nothing wrong with doing some CBT techniques or DBT techniques or whatever else needs to be used to support the intervention. Our referrals are off the street. They're not people asking for psychotherapy. They're not even people who are often diagnosed. In fact, they're rarely diagnosed with BPD. We usually make the first diagnosis. And we don't have selection criteria for psychotherapy. We don't see psychological mindedness, as people in the field call it, as a prerequisite for coming into treatment. We see it as a goal of treatment. That in fact one of the fundamental difficulties that people with BPD have is in developing a sense of being able to step back and reflect upon themselves. They're often in the moment rather than reflecting on it. And so that's actually something that we expect as an outcome of treatment, not a requirement to start treatment. And we're not convinced that individual psychotherapy is necessarily the be-all and end-all of treatment. That in fact there's a lot of other supportive interventions that are often not talked about in the treatment literature that are likely to be very effective. And in fact the trend in most of the studies of intervention for borderline personality disorder is that when you compare them with more generic forms of high quality care, they're usually just as good as those forms of high quality care. That's not the same as treatment as usual. It's high quality care. In particular though, we don't expect to have our cake and eat it too. We don't expect young people who have difficulties with self-management and have difficulties with basically living their lives to somehow magically be able to manage the process of therapy, turning up to appointments on time, even turning up to see us. So we'll go out and see them if needs be, and we have a strong emphasis on early engagement. We're flexible about when and where we see people as much as we can be, but that changes throughout treatment. One of the goals, again, is to begin to hand over responsibility to the individual to be able to begin to manage on their own. There is also, though, a need to balance with some limits to what we have to offer. We live in the real world of limited resources. And we don't read people their rights when they come in. We have an approach that raises difficulties as they occur along the way. Again, just reading people their rights is a very unwelcoming thing to do when people come into a service. So we try to actually anticipate problems, but also raise them along the way and not see these kinds of problems as fatal flaws to engaging in therapy. And I've already really talked about informed refusal. We also offer episodic care. Young people, and I think this, and I suspect actually a lot of adults with BPD who don't get into treatment trials don't necessarily want long-term treatment. They want episodic treatment. Certainly young people tell us that they want to be able to come and go, and they very often say, I've had enough treatment, I feel okay, I want to finish up now. And rather than seeing that as always somehow being sinister, we would check with the person whether that's actually maybe a helpful and caring decision about how they might approach their problems. We also think that intermittent care promotes autonomy rather than dependency on mental health systems. It discourages people from really just becoming entrenched in the mental health system. And there's a practical issue. It also increases throughput. It allows us to see more people. It's primarily individual treatment. We encourage family involvement. One of the unique aspects of this age group is that you're trying to balance the normative developmental challenges of young people wanting to be autonomous and develop independence with the wishes of the family who often want to be involved. And so, unlike childhood or adulthood, it's a much more complicated mix, the period of youth, in terms of trying to balance everybody's needs who's involved in the treatment. We also take a broader view, trying to work with other people in the system. This is not unique to our program, but we think it's an essential element of these programs to work more broadly within the systems that young people are involved in, whether they be part of the mental health system or whether they be other agencies or schools that they're involved with. And we encourage family to be involved in assessment, feedback, and as I said, we have to balance needs with that. And also we need to recognise that many families are struggling with their own difficulties themselves. It's a complex problem which is multifactorial in origin. Hopefully we have moved beyond the era of family blaming toward family understanding that individuals come from families that, just like it's commonplace now for people who are sympathetic in the field to see BPD, individuals with BPD as doing the best they can, I think very often families have done the best that they can, but under difficult circumstances. As John Gunderson once said, parents don't get up in the morning and deliberately decide to make their children's lives worse. Sometimes things happen, but not necessarily because they're intended. The therapy we use is cognitive analytic therapy. I'm not going to go into detail about it, but it's a brief therapy. It's time limited, 16 sessions, and in fact the mean number of sessions that patients in our program have is about 11. So it's not a lot of therapy that they need to actually begin to improve. And one of the advantages, one of the reasons we chose this therapy is that it is time limited, but also it's a relational therapy. It recognises BPD as a relational disorder. We have a high rate of people dropping out, but that's actually common in programs that offer treatment to all comers, and in fact even to selected programs. 30% is actually pretty low compared to a lot of treatment programs, but a lot of those people will come back for a second bite at the cherry. And the focus is actually on having an ending rather than necessarily setting a target that has to be achieved. The average length of treatment is about 7 to 9 months, in fact. People can have multiple episodes of care. We're constrained by our service in only having a 2-year window within which to offer that care. We'd like to have a longer period. And we often don't have opportunities to discharge people to other forms of care. And so about 50% are often discharged to their own care or to non-government agencies, other forms of support. And finally, again, I think early intervention is an important innovation because it actually gives us a window into understanding BPD as well. Understanding and investigating BPD as a problem early in its course gives us a different perspective on the disorder, and we've done a series of studies. I'm not going to go into the data, but again, it provides a novel view of individuals with the disorder so that we can begin to understand some of the developmental processes involved in BPD. There's many people to thank, but I would particularly like to pay tribute to Louise McCutcheon, who's been my co-pilot on this from the beginning, and Henry Jackson and Pat McGorry, who've been supportive from the outset. We have a raft of people who've been involved. That's just a selection of them, and it's been a real team effort, and I am very grateful to all those people. So thank you very much for your attention.
Will you be around for a little while? Yeah. Okay. Andrew's just mentioned that he will be around for a little while should anyone perhaps want to corner him over that shared sandwich at lunchtime.